We are live, sir. You can go ahead.
Good afternoon, everybody. I am Dr. Saumyajit Basu from Kothari Medical Center, Kolkatta. A warm welcome to all of you in this ASSI Pro Series webinar. We've already done quite a few, and today's topic is severe rigid scoliosis. I'm thankful to Dr. Gautam Zaveri and the President and the Secretary of ASSI for having allocated this particular series moderation to me. So, before going further, I'd introduce you with the other panelists in this particular webinar. Dr. Arvind Jaiswal is from New Delhi. He needs no introduction. He is one of the pioneers in scoliosis surgery in the country, and having retired from All India Institute of Medical Sciences, he is now joined privately in Delhi and is still active in clinical practice. Dr. Sajan Hegre needs no introduction. He's one of the senior most spine surgeons in the country, and he is still heading the Department of Spine Surgery at Apollo Medical Hospitals in Chennai. Dr. Ajay Shetty is a consultant spinal surgeon in Coimbatore, Ganga Hospital, Coimbatore, and is currently the secretary of the Association of Spine Surgeons of India. He is doing phenomenal work in the entire gamut of spine surgery. Dr. V.S.P. Rao is a senior spine surgeon in the metropolitan city of Hyderabad. He is now working in Medcover Hospital. That was what I was told. Excuse me if I'm wrong. He initially was there in Nizam's Institute and is now in a multi-specialty private hospital taking care of all spine patients. And finally, Dr. Dheeraj Sonamane is in Lady Hardinge Hospital and JJ Hospitals in Mumbai. He is relatively young, but he's got a fantastic experience and is currently showing up in the deformity circles of the country. So the seminar will go off in 2 hours with 5 case discussions. I've intentionally kept it live interactive with the panelists so that you all can enjoy the case discussions. In each of the cases, we are going to try out what exactly which part of rigid severe scoliosis we are going to cover. For example, the first case would be about the assessment and severity of the rigidity. The clinical and radiological aspects will be discussed by Dr. Dheeraj, followed by another case in which we would be discussing choosing the levels and choosing the implants and the role of intraoperative fraction, which Dr. Sajan Hegre would be covering up for us. And then it would be an osteotomy case in which what types of osteotomy are you going to do in which type of severe scoliosis is the topic of Dr. Rao. And followed by that, the role of anterior release and posterior correction would be taken up by Dr. Arvind Jaiswal after a case discussion again. And the final case discussion would be on the role of halo gravity traction. And Ajay is going to cover that. Each of these lectures by these faculty would be about 8 minutes duration. Before that, we'll be discussing the case, and after the lecture is over, we'll be discussing the solution of the case. So that's how it is going to go about. So before any further wastage of time, I will throw upon the first case to discuss about the assessment and severity of rigidity, clinical and radiological. So this is a 12-year-old premenarchal female child who presented with deformity of the back, which was first noticed during bathing the child at the age of 1 year, in the form of a prominence of the mid-back, and it progressed slowly over the last 10 years. But after that, for the last 1 year, it has been really progressing very rapidly. It is not associated with pain or any other constitutional symptoms, and there is no history of weakness or tingling. But she is the first child at an institution born by normal vaginal delivery. The child cried at birth and is fully immunized and achieved all milestones at appropriate age. Mother took proper antenatal checkups and perinatal period was uneven. I'm sure each of these would be discussed in much more details by Dr. Dheeraj. And this is the patient. Now, before going into this, I'll unshare my screen and ask I will start off with Dr. Arvind Jaiswal in
Can't hear you.
Can't hear you.
Can't hear you, Saumyajit.
I think, sir, there is some issue with his internet. You can share your screen and start.
No, sir is not speaking yet.
Acha, okay. He's just asking a question. Dr. Ajay Shetty, you want to continue where he stopped off?
Yeah, 1 second. Basu? Okay. Okay, right. Thanks. So what are the things you will look at when you have a patient with a rigid scoliosis like this, as in the history per se? Dr. Arvind Jaiswal.
Yeah, it suggests that this the child was a congenital scoliosis. So obviously, and the progression is almost for 12 years, and she's 12 years old now. And so obviously, she's in a neglected deformity. So one would like to also know whether she's been treated earlier or not. And also, then when you come to the examination, you have to look at the spine as such, and also look at if there are any patches of cutaneous markers, and also neurologically if she's been walking, if she's her bladder bowel works are all right, so you keep assessing as you go along.
Dr. Sarjan, you had seen the clinical picture of the patient. What would be more important for you in the clinical picture of that particular child? I mean, how do you assess it as a deformity, as a scoliosis, kyphosis? What is the main element of the deformity? What do you think?
When a child which is known to have had the deformity since age 1, I would like to have pictures of the child when she was younger. If she was seen at a younger age, and if we have some evidence of how she looked when she was much younger. And that would clinically, and now we have not even gone to the x-rays, so we don't know what the deformity is. So looking at the child, she seemed reasonably well balanced. I'm really eagerly waiting to see her x-rays to see exactly what, because she doesn't seem so out of balance. Her shoulders seemed at level, her pelvis seemed at level, and her spine did not appear decompensated to one side or the other. So I'm eagerly waiting to see her x-rays.
That is because her kyphosis appears to be more than scoliosis. At the first glance, it appears to be more kyphosis and a mild scoliosis. That's why
I agree, Arvind. I agree.
That's why the balance is not too much.
Yeah, I agree.
Basu, you are in?
Yeah, I'm in. Sorry, I just got disconnected. I'll once again share my screen and go on with the case discussion.
Basically, we can summarize by looking at the patient's clinical picture is that her kyphosis is the main element, which is probably at the dorsolumbar junction. And since there is an element of kyphosis, most likely it's an congenital variant rather than being an idiopathic scoliosis of early onset. I mean, that looks to be the clinical picture as such.
What is also important at this stage is to rule out any syndromic involvements also, and that in a younger child, that should also be looked into.
Till Basu comes in. Surya
Yes.
Prakash, if you're doing a clinical evaluation, what are the important things we'll look for? General.
And also, I think it's very important to know whether the girl is, what is the height of the parents actually, and how tall she is expected to grow, and how at what stage of the growth spurt she is in. Looks like, I think I didn't carefully follow about her menarchal status, but that's really very, very important for us before we consider any treatment plan.
So she was about spastic in both the lower limbs, and gross power was about 4/5. And as we come across with the assessment, I will show you the X-ray, MRI, and CT, and then again ask Dr. Dhiraj Sonamane to go through his talk so that we can again come back after the talk is over. So this is 85, very, very rigid, sharp, knuckle-like deformity. And this is the MRI. And as understood that she was spastic, and you can see that the cord is actually getting pinched on the concave pedicle. So there is the concave pedicle getting the pinching of the cord, and as you can see that the cord is pushed against the pedicle of the concave vertebra, and that is the CT scan.
Basu, again we can't hear you.
I think Dheeraj, you can go on with your talk, and then we'll come back to discussion again.
Sure, sir. Neeraj, can I share my screen?
Yes.
Yeah. Can you see my talk?
Yes, Dheeraj,
So you
please
can
go
see.
ahead.
Yeah. Yeah.
We can see and hear you.
Yeah. Good evening, everyone. I thank ASSI for this great opportunity. I am Dr. Dheeraj Sunane. I work as an associate professor in Grand Government Medical College, and this year it has completed 175 years of medical education. So my talk is on clinical radiological assessment of severe rigid scoliosis. So severe and rigid. So severe, as per definition for scoliosis, is a more than 90-degree Cobb's angle, and rigid we assess by taking bending views. And if the bending is less than 30% of the whole Cobb's angle, it is called to be rigid scoliosis. So for example, if it's more 100-degree Cobb's angle and on bending it is 70-degree and plus, so it is considered as a rigid scoliosis. So why the assessment of flexibility is important? So it helps us during plan, amount of anchorage and instrumentation required for the spine for a better correction. More extensive surgeries is required, and the risk of blood loss, the more osteotomies, and risk of neurological deficit increases. Many times patient may need a staged approach. There may be requirement of halotraction, or it might require anterior or posterior two-stage. So on history, we look for deformity, we look for pain and neurological symptoms, complaints. Okay, pain is an important symptom, especially it gives a suspicion of atypical curves, and there may be some underlying pathology like discitis, a tumor, okay, which has to be taken care. The deformity has to be progressive or whether it is static, and the duration of the deformity has to be asked to classify the curve. We have to also ask for the GUT complaints, and maturity history has to be taken. As Dr. Rao has just mentioned, the parental height, especially if a male has to be compared with his father and a girl has to be compared with a mother. Birth history and family history is also important. Developmental history and school performance with his peer has to be taken. So on general appearance, you can see there is a shoulder in this case is balanced. There is a severe hypokyphosis in the thoracic region with proximal thoracic kyphosis. Overall, the alignment in the sagittal as well as coronal is okay. There is a right-sided hip prominence. There is no signs of spinal raphism and capillary spot, and both ASIs has to be assessed whether it is at same level or not. So this is another case. You can see right shoulder is higher, right side rib hump. There is left side iliacostal impingement, and C7 plump line is well centered. There is a hip prominence on the left side, and both ASIs in this case also is at the same level. You can measure the Cobb's angle in height as well as in angle, and this angle has to be measured in every follow-up to see whether it is progressing or not. So apart from these are the signs of a typical scoliotic curve. If there is associated chest deformity, in right upper side we can see a cafe alert spot in the patient. More than 5 cafe alert spots suggestive of neurofibromatosis. A lower down image suggests a proximal kyphosis, which is in this patient it was a neurofibromatosis, which is highly suggestive of neurofibromatosis association. Obviously, we can see nodules and localized increase localized severe deformities if less than six segment suggestive of more of a congenital severe deformity. You can also look for signs of spinal dysraphism. In this patient, you can also see for a scrotal, on a scrotal exam, you can see there is a swelling in the scrotum. So this has to be examined every time. So for on clinical assessment, so we check for the bending as we do the X-ray. We check similarly we check for the bending which to look for the correction of the deformity. If we get traction views, we ask the patient to hang on the part to look for the stretching. Skull lift and push prone to as shown in next set. Thanks to Shitish. So we push prone test we do in clinic. We do while taking X-ray. Also we do it on table while correcting the deformity. So this is the same procedure which we do all the time. Traction view, we lift the patient, especially teenagers, we lift the patient with skull and see the correction and flexibility of the spine. So these are standard 14 by 36 inches X-ray, which includes C7 to the subtrochanteric region. And it's a 126-degree Cobb's angle with no signs of bony, congenital bony anomalies. On bending, it was 110 degrees. But for bending, there is a limitation. For more than 70-degree curve, is considered to be go towards traction views rather than following the bending views, because there is also restriction because of the iliac crest impingement. So traction view is what we preferred for a severe curve. In this, from 126 degree, it was bending to 110 degree, and it is considered severe. Supine AP and push prone view are the two other views. Supine view, especially when we consider supine view, when there is a discrepancy between lower instrumented vertebra, whether it has to get L3 or L4. In a case, suppose L4 is a stable vertebra and we consider to preserve a level, and L3 is just touching vertebra. On supine AP, if it becomes stable, then we prefer to go for supine view L3 stable. So other views are erect seating view, which is done for non-ambulatory patient, fulcrum views, and stagnar view. The importance of stagnar view, especially to avoid hanger's effect. I will explain what is hanger effect in the next one. And prone intraoperative, especially after giving tractions intraoperatively. Also after giving a GA, so there is a you can assess the LI in these cases. Assessment of pelvic obliquity, in this case you can see there is left hip is slightly lower and ASS in this patient was slightly lower. So we have to also assess for pelvic obliquity all of the severe deformities. But this case there was a trick. The limb length on assessment, the limb length was normal. So if you see on the lateral view, the left hip is more contracted and left knee is more contracted, which gives us a false sense of limb length discrepancy. Other assessment is CT. So in case of syndromic features, we have to do CT, and which tells us about the pedicle type, size of the pedicle, and the angle. Sir. So these cases we can see the pedicle diameter, and we can see whether in a Sach cut we can see whether anterior construction is possible. We can see unsegmented bar. This is a normal looking AIS on X-ray. We won't able to differentiate. The CT tell us about the fusion of the vertebra. This is a hanger effect. If we see a hanger, it has a normal 60-degree angle. If we see this hanger at a 45-degree, so the angle, the Cobb's angle might be reduced from 60 to 30 degree, and in the end-on view, it might be seen as no deformity. So in this case, CT might be helpful. CT is also helpful to look for a laminar defect, which may be causing disaster during the surgery. So when to do a MRI? So if there is a typical looking curve, and if there is imaging finding of interpedicle wide interpedicle vital foramens, in a clinical scenario with a younger child with more than 20-degree curve, associated back pain, unusual curve, and hypokyphosis, this associates some neurological. All these are indicators for the or getting the MRI done. So this is an example. This was a girl child with a left-sided curve and some hyperkyphos, and we can see there is little less rotation of the vertebra. The pedicle is not that rotated, and the Cobb's was 98 degree. So we have done an MRI, and this turns out to be Arnold Chiari. So other features like diastrophy and other anomalies can be detected. See, as the case previously case shown in Basu sir's case, we can see the approximation of the cord with the corresponding pedicle, and when we can correlate with the CT, and they decide how the trajectory has to be taken. Other newer tests like MRI texture analysis has been coming up to assess the flexibility of the spine. Thank you.
Thank you, Dheeraj. Could you unshare your screen, please?
Sir.
Right. So, Ajay, I'd ask you about when do you do any other investigations other than CT, MRI, and X-ray?
See, for me, the most important thing when you have a patient with a severe scoliosis is not only the assessment of the deformity, the assessment of the person per se, like assessing his general condition, assessing his nutrition, assessing the other system, respiratory function. These are the most important aspects. Because most of these children are most of these around 10 to 20 years of age. They are nutritionally compromised. The skin will be very thin over the deformity, and their respiratory function could be compromised, because this is the most important thing. Regarding the need for X-rays, as Dheeraj mentioned, always a traction X-ray, because bending X-ray, there is a costopelvic impingement. You do not get a proper assessment. MRI is necessary in all patients. There is no doubt about that. And CT also is necessary to analyze the exactness of the deformity, because once it crosses 90 to 100 degrees, there is a significant anatomical variation on what we see, and therefore we need to get investigations on that aspect.
Right. Dr. Jaiswal, when do you do an ultrasound of the whole abdomen in these patients?
If you're suspecting a syndrome in young congenitals, these are the two types which you predominantly do an ultrasound and get a pediatrician actually to come in and do it. And particularly in congenital and EOS, early onset scoliosis, we routinely have a pediatrician getting involved to look at the syndromic surge, look at the genetic aspect, and if there's anything else which we may sort of not be able to pick up in our outpatient, which is grossly like an ultrasound abdomen, the pediatrician itself would do it. So number one in congenitals, number two in early onset scoliosis of all varieties, we would have a pediatrician to look at it, and then they will sort of organize their investigation.
Right. So before Dr. Sajan comes up with his talk, I'll just show you what we did with this patient. This was a 80 degrees kyphoscoliosis, and it is a very standard vertebral column osteotomy with closing wedge osteotomy with a cage in front acting as the fulcrum. So from 85, we could correct to about 40. So about a 60% correction that we did. Pretty modest. I wouldn't say it was a very radical correction, but she did well. And these are the immediate postoperative pictures. So the next case, which we are going to discuss.
What about her neurology?
For that, yes, I'll take a comment. Yes, please.
Yeah, her neurology.
Sorry, the neurology, as I shared with you, it remained grade 4. She still comes in a follow-up. It's about 3-4 years. She still has some hyperreflexia in the lower limbs, and I sort of strongly believe that once the cord gets certain subtle changes, they are very unlikely to get reversed. All you can do is to stop progression. And in these sharp kyphosis rather than scoliosis, in which the cord gets impinged on the concave pedicle, once they develop a deficit, it's very difficult to reverse that, whatever small it might be. So your experience followed by Dheeraj.
Do you make an effort to sort of, like you said, you had impingement features on your MRI and CT. Do you make a sort of an effort to do a laminectomy, decompress, and try to remove the medial pedicle where it's impinging, or you just try to get your correction and then probably you feel the cord will get off the impinged pedicle, the concave pedicle?
So in these particular cases of VCR, when I'm doing an all-round removal of all bony tissue all around the cord, it obviously gets decompressed on all its aspects. But if I am not planning to do so, then I would not give in a very severe attempt to take out the entire concave pedicle. I will rely on my correction for decompression. But in these cases, when I have already planned, as I showed you in the template, I already planned to take out that particular amount of bone. This is the template which I always have on surgery hanging in front of me. So here you see that I have already planned to take this entire wedge out. Then obviously the pedicle, the concave pedicle goes out. So
Yeah,
I
so
hope that
you
answers
should
your
make an
question.
effort to remove the concave pedicle first. That is what I was trying to put at, right?
Yes, it is
When you do a
extremely
laminectomy,
important.
first get the concave out and then do your osteotomy and your VCR, whatever, right? Otherwise, if you don't remove that, the signal further falls, and that's been my experience also. So
Yes, so we
concave.
will be coming to the techniques in Dr. VSP Rao's talk, sir. These would be
Okay,
the
sure.
points which I'll be looking forwards for once
Sure.
Dr. VSP Rao finishes off. Dhiraj, you had one comment before we'll move on.
Yeah, same thing about the pedicle, which
Right.
I attempt to take the pedicle out first. Sometimes two pedicles are involved. I take out two pedicles first. After that, I
Right. We'll come
proceed
to the
with
steps
the
of
guys.
surgery once Dr. VSP Rao finishes his topic. So this was what we did. And go on to the next case. This is about choosing the levels. I would just start off with the case and ask Dr. Sarjan to complete his talk. So this is a deformity of the back. She's a 14-year-old male patient who had a deformity of the back and delayed development of milestones. She couldn't stand up or walk at the normal time. And that's why his parents got a bit worried. And mother said that at 4 years, he went on hunting around with pediatricians across the length and breadth of the city and finally was diagnosed as SMA. And he was on physio. He became a walker just with a little bit of a support, but he never was an ambulant independent ambulator. He became a non-walker by the age of 8 years, and now at 14 years he presents with difficulty in sitting erect. He has multiple joint contractures and wasting of limbs. Sitting balance is severely impaired. Severe kyphoscoliosis present over the back. Neck holding is present. We were lucky about this. And there was a pressure sore developing on the buttock due to abnormal weight distribution while sitting. And this is the child. As you can see, she hardly can sit. He half lies down on the wheelchair, and that is the only way he can sit. And this is how he needs to be propped up. And you can always see the pelvic obliquity and the wasted limbs and the contractures of the wrist and ankles and knee to tell you all. So this was the X-ray, and as you can see, the first attempt at X-ray by the radiographer was a wastage of time and effort because he could not show the pelvis. So he had to be set up on an elevated pillow so that at least his pelvis obliquity, howsoever horrendous it might look, at least came up on the X-ray, because otherwise, if he was sitting normally without a pillow on the wheelchair, we could not see his pelvis on the X-ray. So before going into the management, in these particular cases, I will ask Dr. Sajan Henry to please share his huge experience on this issue and tell us about the levels he would choose and the implants he would choose and the techniques he would apply for correction of these severe curves. Dr. Sajan, you can share your screen. Thanks.
Mute me, no? Good evening, gentlemen. Very interesting discussion. So it's good to be back. And so I'm just going to show a case of a severe deformity and discuss how I choose my levels, what implants that I put in, and the role of intraoperative traction. So I just put together these various papers. I think what Arvind will speak will be closest to what Bradford and others did way back in the 90s and earlier. That is anterior release and posterior correction. Now, treatment of these very severe deformities has been associated with extreme blood loss. Bradford's series of 24 cases, he had 5,500 ml of blood loss, neurological complications in 3 cases out of 24. And he was not doing a PSO. He was doing a front and back. And then, of course, you have Dr. Suk from Korea. his experience. And in his experience of 16, now we all know Dr. Suk is a pioneer in severe deformity correction, the first one to use pedicle screws in the thoracic spine. And in his series of 16 cases, he had 2 paraplegias. There were the average blood loss was 7,000 ml and other complications. Lenke reported in his series much less blood loss and no neurological injuries. So here we have a 15-year-old girl with severe deformity, which was noted at 12 years of age. These are the pictures. We took these pictures just before she was taken into the theater. And you can see that not only she has a severe deformity of the spine, but there are bony changes in the rib cage causing this sharp angular gibbous. And this is something that I will talk about as well. I hear voice. I think Dr. Chabra is talking. Is Dr. Chabra talking somewhere?
Can everybody mute, please?
So this is the deformity. This is the gibbous. This is, so the spine, not only there is deformity of the spine, the chest has already undergone significant deformation as well. So her neurological examination was normal, her spinal cord MRI was normal, which we always do as a routine for all the cases. And this is what we started off with. Her Cobb's angle was almost 120 degrees. She was Risser's 5 and Sanders 8. So in my setup, we always do, we made the bend films, but we also do the traction film. For us, the traction film is a must for every deformity. So we did the traction at 120 degrees. It came to about 100 degrees. So in our setup, we now believe in putting these severe deformities on halo traction, which Joy will talk about in a while. And we keep them for about 4 to 6 weeks, depending on how severe the deformity is. So you see on day 7, her Cobb's angle was 90 degrees. On day 15, we have increased the weight a little bit on the halo, and her Cobb's angle has come down to 75 degrees. And then on day 23, the Cobb's angle is 65 degrees. So this is when we think it's a good time to go in. And so we have achieved 45% of correction in 3 weeks. And this is how I plan my instrumentation. I am a surgeon who does not believe in fixing every vertebra. Even in standard scoliosis, I believe in fixing strategic vertebrae. So now I still hear somebody's voice. I plan my correction with my implants on the traction film. Here on the concave side, you can see the pedicles are well formed and easy to get. So I want a good foundation at the top of the concavity of the deformed spine. I would have usually done a CT scan, and if the pedicles are extremely dysplastic on the concave side, I would prefer not to use pedicle screws on the concave side. And here I may use bands. And of course, then there is a foundation. And depending on the traction film, I would decide where to end my correction And of course, distally, we would strategically place pedicle screws at every level. On the convex side, so here you see, this is the upper part. This is the most deformed part. This is the lower part. And at the top on the convex side, I would always believe that getting pedicle screws at the top, I feel their hold is often very inefficient. I prefer to use a claw with hooks. So there will be a supralaminar hook and there will be a pedicle hook at the top, and then there will be screws in the lower vertebrae. And of course, then I would get at least 2 or 3 screws on the convex side. These are relatively easy to get, and of course, distally. My instrumentation will start always on the concave side, and I may often use a solid rod, that is what is it? The cobalt chrome rod. And on the convex side, I would use a more straighter, typical titanium rod. So this is how it is done. Now, Dr. Azmi from Turkey, I think it is only his paper where he has used intraoperative halofemoral traction and done instrumentation. He does not do any VCRs or any other vertebra excision procedures. He uses femoral skeletal traction. We do not use femoral skeletal traction. We prefer to use skin traction, as you see here. So the patient is on traction, on skull traction and skin traction distally. And then we take an AP view to decide where we will stop. And we do this even in our regular scoliosis. So this is the instrumentation. Before we start, we do a spin with the 3D C-arm. And use the robot for quickly finishing the instrumentation distally. And then use the mesonex in the concave part to do the osteotomies, the SPOs or the pontes to release. We would also release the soft tissues. And after doing the instrumentation, we would expose. Now, I believe in doing a gibbous excision. I don't know, this is something, Arvind, I would like to talk about later, but I do believe when there are structural changes in the ribs, there is no way you can reduce the rib hump. And the best way is, and we use the mesonex to neatly cut the ribs. And this, of course, gives us the bone graft. And then we do the instrumentation. So you have the upper construct, you have the bands, you have the lower constructs, and a deformity of 120 degrees is reduced to 28 degrees. So this is a correction of almost 78%. Azmi in his series got a correction of about 50%. So this is how she looks pre-op, and this is how she looks post-op. So my message here is to make these what can be potentially dangerous surgeries extremely precise, extremely safe, and extremely predictable. And the blood loss for us in this particular surgery was around, what was the blood loss? 650 ml. And when I scrub in, it is about 2.5 hours I take for my entire stay during the surgery. Thank you.
Thank you, Dr. Sajan. Can you please unshare your screen? So Ajay, in the case which Dr. Dr. Sajan Hegre showed us, would you really believe that the traction worked or the intraoperative releases worked? Dr. Ajay?
Yes, to unmute.
Ajay, are you there?
Does help in this scenario. It makes your surgical procedure much more simpler. But usually a curve up to 90 to 95 degrees, you can get away by intraoperative releases itself. But however, as Dr. Sajan showed, the magnitude of your surgery, the patient's tolerance towards the procedure becomes significantly better. But basically in a severe deformity, what I would say is that you don't have to compromise on the levels. You have to go from stable to stable vertebra. Usually your fixation will be much more longer. You go either from T2 to T4 above or from L3 or L4, most of the scenarios of severe rigid deformities.
So Ajay, what would be your levels of fixation in this particular case, which I had showed you? And still we go on with the management.
Yeah, this patient, if you are planning to consider a surgical intervention, I mean, SMA, the complications are much higher. It definitely needs to go into the pelvis because there is a significant pelvic obliquity. The aim of the surgery is only to regain the sitting balance. And therefore, you usually go, because the kyphotic element is more from T2 to the pelvis. I mean, that's what my idea would be.
And Dr. VSP Rao, would you have any difference of opinion regarding these surgeries?
I think that going to pelvis is a must because there is a gross pelvic imbalance, and the idea is to make the patient sit straight. And of course, the proximal extent should be a T2 or T3. I think preoperatively, I think some form of a traction would be useful in her. If at all she can be put in the ward for a long period of time before surgery, because I think she needs to be optimized for surgery as well, because she looks thoroughly malnourished. Her hemoglobin must be very less. So in all this, as you are increasing, sometimes these people need a gastrostomy or something like that, feeding tube, to improve their nutrition. So I think once you do all this, then she will be fit enough for a good pelvic fixation and proximal fixation up to T2.
So initially we were not sure
may I say
whether
something?
Saumyajit, can I come in here?
Yeah.
See, yes, you have to go into the pelvis to get a good correction. That has been the concept over a long period of time in these severe neuromuscular scoliosis. But in SMA, there's an issue now. You know, most of these, a lot of these patients now need an intrathecal drug delivery. So there's a big question mark, and the parents come and ask you if you fuse them right down to L5 and S1, how would the intrathecal, drug be given to these patients? That has been the issue in last two patients of ours. And so we stopped at L4 and left the L5 S1 virginal. In this particular case, the pelvic cavity was a huge aspect. Probably we will need to go ahead, but keep that in mind. The newer patients of SMA, they all come with the thing that future, there is an intrathecal drug which is coming through, and they are on the internet. They are very savvy about, and they'll ask you after say 5 years or so, will the patient, when these drugs evolve, will they be able to be given an intrathecal drug? So this is an issue. Have you faced that?
So I'm actually attached with the SMA Foundation of India, and they have now come out with the statement in the COVID period. In fact, I also contributed to that in the spinal point of view. This drug, which the government of India is still not very sure whether it's going to bring in or not because of the huge.
Yeah, but in the US it's coming. Yeah.
Yes. And the problem is this drug needs to be given in very, very young children before they develop a very full-blown deformity. Now, once they start to develop the deformity, they go downhill and they go on and on and on. For example, in a patient who has this sort of deformity at 14 years of age, definitely would not benefit anything by putting in that drug. That drug is basically based at putting in those at usage below 4 or 5 years before the deformity has really picked up well. And for all those patients, as you correctly put in, either you have a pre-arranged window where you can deliver the drug into the thecal sac, or you have to leave at least 2 segments of the spine so that the drug can be delivered by repeated intrathecal puncture. And
Yeah.
in this particular patient, we just put him on a halo. I was not sure, as Ajay correctly pointed out, they are very, very morbid patients. And we were not very sure whether we could ultimately do the surgery or not. But putting him on a halo, actually, and the physios working on his nutrition and chest, really give him a new life. I never sort of imagined that I ultimately would be able to do surgery with serial. She was on about 3 months on a halo. He improved weight, his feeding improved, his sitting balance improved. And as you can see on a supine film, this is his supine film, he improved so much in the next 3 months. This is his film in a halo, and this is how he was. Initially, he was halo on the bed, then he was halo with the wheelchair, and that was how we ultimately had a very, very serious consenting. Multiple areas of consenting was taken up. All parents were sort of made aware of a possible risk of morbidity and mortality. We quoted about a 30% chance of mortality, and ultimately we could do it in stages. The anesthetist was very sure that we are not going to do it in a single stage. Due to paucity of time, I'm not really going into the steps of surgery, but the first step was T11 to T10 to pelvis, and I put in rods, corrected as much as possible, and then left him. With a 2 week period, he was again put on a halo, and again he slowly and steadily took the shock of the first surgery within the next 3 weeks. 3 weeks later, we again went back. We didn't open up the lower part, we opened up the upper part and put in dominoes to connect the 4 mm. The upper construct was 4 mm, 4.5 mm rod, and the lower one was 5.5 rod. So we put in a domino to connect those two. The upper vertebrae were so small and thin, and the skin was so, the subcutaneous tissue was so less that I didn't risk putting in a 5.5 rod because of implant prominence. And so this is what it is. And this is what he is 2 weeks after the surgery. And it's now about 6 months after the surgery. We are still lucky that he's holding his neck well, but to be prophylactically sure we have such a large amount of fixed spine, the upper part of the neck is going to wobble. So we've put him on a sort of a Somi brace when he's sitting up, and he is really, really very happy that he can see the world with his own eyes sitting upright. This is what the pre and post-operative supine films, and this is the pre and post-operative erect films or sitting films for comparison. Any comments before we go on to the next case?
Great correction. And it's very important that you don't leave it at the first stage, which you rightly said you had to go up, because you need to go and cross your thoracic spine, because that would also help the patient get his chest out of the pelvis and help the pulmonary function to a large extent. So you need to fix them up right from T2, T3 to right down to the pelvis. Yeah. But okay, we'll talk about it later.
Yeah.
Later, yeah. Okay.
Yeah, just was speaking about something else.
Yeah, no, about SMA itself. Now they're giving in adolescent patients also in the US and UK, and there's a big concern about that. So please keep that in mind when you get your SMA cases, to look at the literature, because you might line up in problem if that intrathecal developed drug which is developing rather fast, and they might say that why didn't you leave a window in L5S1 for intrathecal thing. So for everybody else, keep that in mind in SMAs.
And before we go on to the next case, I would ask you all to tell me one simple thing, I think, which all the viewers need to realize. So for example, if a patient comes to you at 1 year with a congenital scoliosis, when would you ask for an MRI? I would ask this to each and every one of the panelists, because this is something which many people ask me. that we all know that neuraxial anomalies are quite common in congenital scoliosis, but considering that a child has come to you for at the age of 1 year or 1.5 years, where you're not going to do any surgery on him, are you going to do an MRI? I'll take the panelists one by one. Dheeraj.
Yeah.
When do you do the MRI?
So for unless there is a neurological deficit, he is not moving his limbs. If he is less than 1 year, and when he should be standing and walking, there is he is unable to do that. If that suggestion of early neurological involvement, then only I will go for a MRI. If there is a signs of spinal dysraphism, then I will go for a MRI. Otherwise, since I am not going to intervene, I usually avoid doing it.
And Dr. Jaiswal?
As soon as I see the patient, I'll get an MRI done. Very high incidence of spinal cord abnormality, and I would look at it. Not only the tether, not only diastematablia, even the upper cervical spine. So a complete MRI has to be done, evaluated right in the beginning, even if it
Dr.
has
Hegde?
even if it has to be repeated later on.
In our setup, I would send to the pediatric neurologist and take their opinion and take their inputs on whether we should do an MRI or not. Well, before considering any intervention, an MRI is a must. So if the pediatric neurologist, after examination, feels they need one, I think it should be done, of course.
What about Ajay?
See, I agree with the fact that in a child without any neurological abnormalities, any evidence of spinal dysraphism, I would prefer to wait till the child doesn't need an anesthesia to get an MRI scan done. That would be my primary aim, to add an anesthesia in a child. But
that's very relative, Ajay.
Yeah, that's the fact. The thing is that whether you are planning to operate, whether we are going to do intervention, it is any neurological abnormality, I would get it done early. Otherwise, I would prefer to wait till the child is about 2 to 3 years of age, where you can sedate and get it done. But the important thing is that when I'm asking for MRI in any child with early onset scoliosis, I prefer to get a coronal images so that it obviates a need for a CT scan at a very early age. CT scan should be done only if you are contemplating surgery.
And what about VSP?
Generally, in my practice, we have been doing it only before intervention. Earlier, only if they have had some issues, they are having some problems, unable to walk, some delayed milestones, or some problem or the other, then only we force them to get an MRI done. If the child is otherwise normal neurologically, we are holding on until we plan an intervention. But I think after hearing what Jaiswal has said, I think if it is possible, it is probably an ideal situation to get MRI done for every child whenever you see him for the first time with congenital scoliosis. But this sometimes is not very practical. But yes, ideally, every child should undergo an MRI as soon as they are come to a spine surgeon's preview.
So I would go on to this particular 4-year-old female child and show you how Dr. Jaiswal is so correct. I mean, all these patients do have neuraxial issues. They might not have neuraxial congenital anomalies, but if you look at this particular child, which is the next cases discussion before I hand over to Dr. Boletti for asking him to give his talk on the types of osteotomy. So this is a 4-year-old child who had gradually progressive deformity and saw me at the age of 4 years. At that point in time, he was just having the deformity, a very rigid, stiff deformity. And the mother told me that it was 1.5 years when she picked up the deformity and couldn't convince her husband to come and visit a doctor. So immediately I asked for X-rays, MRIs, which was completely lost to follow-up, and came back only 2.5 years later with frank evidence of myelopathy, can't walks with support only, and they have increased episodes of bedwetting since the last 3 weeks. And if you look at him, look at her at 6 years, she has already developed a very, very horrendous deformity. And this poor child, as you can see, walks with a severely myelopathic gait and only has to hold her mom in one hand before she can walk. She's completely dragging the left lower limb. Otherwise, she's a very hale and hearty, beautiful child. And this is what her x-rays look like. This is the supine x-rays, as you can see. These are supine x-rays, and that is how the standing film, if you look at the standing film, not only in the coronal deformity wise, but if you look at the amount of sagittal deformity which she develops, this is the supine film and this is the standing film. You see that the C2 plumb line is way ahead of the hips, and this entire leverage action is happening at the apex of the deformity. And before we go further on, I'll just show you the images before Dr. Boletti takes up the talk. And this is the coronal CT scans. As Dr. Ajay was saying, that before intervention, we really require three-dimensional CT scans. And as you can see, the deformity is such that it digs into the chest wall, chest cavity on one side. And look at the coronal sections, they dig into the canal and gets this severe myelopathy. If you look at the chest part of the CT also, it is really poor and she is already developing thoracic insufficiency. This is the deformity, and as is well appreciated, these deformities can only be correctly viewed upon, correctly appreciated with this three-dimensional understanding of the same. MRI unfortunately doesn't show you much, but before going into the management, I'll de-share my screen, come back to this patient a little while later while we hear what Dr. Suryaprakash Boletti has to say. Please share your screen, sir, so that we can go ahead with your talk. You're muted. You're muted, Surya. Yeah, thanks.
Yeah, because host has muted me. 1 minute. Yeah, am I audible? Hello?
Yes, sir.
Yeah, you are audible. Surya, go ahead.
Yeah,
You're visible and audible.
Posterior column osteotomies, pedicle subtraction osteotomies, and vertebral column dissections. In management of rigid scoliosis has been an eternal challenge for all deformity surgeons. Preoperative traction and intraoperative traction during planned posterior procedures, followed by anterior release and post-instrumented fusion. Then partial complete vertebrectomy using front and back procedures have come. And now all these procedures are done from the back, because with the use of pedicle screws and strong instrumentation, we are able to provide good purchase of the implants above and below the level of the osteotomy. So these vertebral column dissections from the back have become very popular and accepted. In this short lecture, we'd like to look at the indications, types of osteotomy techniques and their classification, and types of these imbalances and clinical conditions, and the choice of osteotomies with examples. Rigid scoliosis for additional correction of deformity, congenital scoliosis with a stiff apex, sometimes an ankylosed spine with severe kyphotic deformity. And remember, all these procedures are associated with spinal column shortening. As an ankylosed spine, like ankylosing spondylitis, non-ankylosed rigid spine, simple rigid scoliosis, neglected idiopathic scoliosis, stiff or neglected Schurman's kyphosis, then obvious congenital deformity, hemivertebra, mixed anomalies, severe kyphosis, then in miscellaneous conditions like post-traumatic and post-tuberculous conditions. Coming to posterior column osteotomies, it's essentially a spinal column loosening procedures where the posterior elements are disconnected by doing facetectomy, Smith-Peterson and Pontis osteotomy. We will differentiate between the two later. And then before we go down, with just a couple of understanding about sagittal imbalance. There is, Bridwell has described the two types of sagittal imbalances, type 1 and type 2. Whereas in type 1, though the patient has got a segmental problem, the spine proximally and distally to the kyphotic segment is able to maintain the balance. But in type 2, it is not able to maintain the balance, so the patient is always falling forward or sagittally imbalanced. And as far as the coronal balance is concerned, if it is a smooth curve onto one side with, say, right shoulder high and right pelvis low, shortening on one side is going to help the deformity by means of an asymmetric sort of a pedicle subtraction osteotomy. But whereas in this type of a deformity where there is the shoulder is high and the pelvis is high on the same side, then one needs to do a vertebral column resection where a lot of bone needs to be removed from either side to adequately coronally balance the spine. This final osteotomy classification has come to understand as we increase the type of, when increase the severity of the osteotomy, it goes from 1 to 6. And here in grade 1, grade 2, 3, 4. Grade 1 and 2 are essentially what we call the posterior column osteotomies. Grade 3 is the pedicle subtraction osteotomy. Grade 4 is a little bit of an extension of pedicle subtraction osteotomy. And here we have the vertebral column resection based on the number of the vertebra and the amount of disc resected above below the segment. This is the partial facet, this is a complete facet, this is the wedge resection, pedicle subtraction osteotomy. Then this is pedicle subtraction osteotomy with the superior disc removed. This is also known as the corner osteotomy, and these are vertebral column resections. Coming to split position osteotomy, where basically a certain amount of posterior column is resected with ligament flavum, lamae and all, and sort of give a correction, and which basically relies on either anterior osteoclasis or a disc-based mobility to achieve correction. It is classically described with ankylosing spondylitis, where this osteoclasis was responsible for a lot of complications. And per se, it sometimes needed an anterior structural graft. So this is no longer used anymore. Now the variant which was described as a multi-segmental quality osteotomy is very popular, where bilateral extended facetectomy is done. Generous undercutting of the lamina is crucial because it's essentially a posterior column sort of compressing or a shortening procedure, and the segmental multiple compressions will help in correcting the kyphotic deformity. Here, basically, it is very important to check on the MRI scan, especially in upper lumbar spine, before we do this procedure, that in case of any pre-existing disc problem, because of the compression, there is a possibility of some disc extrusion happening, because it's essentially a posterior column procedure. Essentially, in a kyphosis like this, the screws are implanted, and then there is a wide resection of the ligamentum flavum and bilateral facet joints here, and then this disc is mobile here, and using the mobility of the disc, the proximal segments are fixed and spine is cantilevered to give the effective correction. And when the anterior segment is fused, or there is a more amount of correction required per segment, then one adapts to the pedicle subtraction osteotomy. Essentially, through posterior approach, a wedge transpedicular encapsulation wedge is resected. Then adequate resection of the posterior elements and pedicle stumps are done, and green sticking of the anterior vertebral wall and closure of the osteotomy is done, so that you get a superforamen where the two nerve roots come out of this, and then at this level, almost 30 to 35 degrees of correction can be achieved. And it is very important that because it is an acutely lordosing procedure in a pre-existing kyphotic or a neutral spine, it is important that the central neural structures are visualized, so that we hydrodynamically not cause pressure on the neural tissue. 35 degrees of kyphosis at lumbar level and 30 degrees at thoracic level, usually used more for sagittal correction, and only when it is done asymmetrically, that is, more bone is removed on one side as compared to the other side, you cannot do a coronal correction with this. And it is very important that bone-to-bone contact is important. This variation where the superior disc is removed is also known as the corner variant. For a condition like this, you can still do a multi-segmental posterior column osteotomies, because the discs are not ankylosed. But in a condition like this, PCO or VCR is mandatory. Coming to vertebral column resection, very severe deformities where there is almost 2 to 3 segments of posterior elements are resected, then the dura is protected and the anterior vertebral column is resected through the posterior elements, and thoroughly spinal cord is sort of 360 degrees it is exposed, and roots are also checked. In the thoracic spine, sometimes for access purpose, maybe a couple of roots may be sacrificed, but again, it depends on the level. Then, before we do all this, it is very important that proximally and distally anchored spectral screws are placed and the temporary rod has been placed so as to not to have a sudden movement or sudden, injury to the dural sac here. And then slowly, as the surgery is done, the spine is cantilevered and manipulated into correction. So here, the more vertebral instability is created so that you can correct a more amount of deformity. It is an extremely powerful that it can correct the deformity in both the planes. There is a need for temporary stabilizing rod and good fixation proximally and distally. And it becomes really a challenge when treating these conditions, especially at the cervicothoracic junction or at the lumbosacral junction, because of the paucity of the fixation points on either side. And sometimes when there is not possible to have a bone contact, it is very important to put a bone graft or a cage anteriorly so as to have a good fusion. This algorithm which I put from textbook, if the deformity is fused anteriorly, yes, the patient will, depending on the sagittal balance correction requisition, patient can go for a pedicle substruction osteotomy and vertebral column section. If it is not fused, but still it needs more correction, then again we need to do either VCR or a VCO. Otherwise, a posterior multisegmental osteotomist will suffice to give a good correction. Remember, posterior multisegmental osteotomist, it is very difficult to get any correction in the coronal plane. It is only possible in the sagittal plane. Well, it's a very effective for kyphosis correction and scoliosis associated with significant kyphosis. But then these are not really good for treating lordotic or hypokyphotic scoliosis. They are associated with significant blood loss and of course this takes longer. Coming to some cases, this is a post-tuberculous kyphosis here, where this is treated with a sort of a modified pedicle subtraction osteotomy here, and then this is a long-term follow-up. And this is again a post-traumatic kyphosis here. Nice wedge resection is done. This is MRI scan, and then we could get a good decent correction here. And then this is the long-term 5-year follow-up. Everything is deformed. And this is again a post-traumatic kyphosis here, where again we had done a pedicle subtraction osteotomy to correct the deformity. The Schulman's kyphosis, yeah, we did a polysegmental osteotomy for correction of the deformity here, and that's the clinical picture. Again, in an ankylosed spine with a fixed deformity, again this needed a pedicle subtraction osteotomy, where we have acutely locked of the segment and gave him a good balance. And this is the posterior corner hemivertebra with severe kyphosis here. Again, treated with a pedicle subtraction osteotomy, where the bone-on-bone asymmetric pedicle subtraction osteotomy with a decent correction. This is a pre and post picture. And this is a very severe kyphotic sort of a scoliosis, a very stiff curve. And if you can see the hyperextension film, where we have taken hardly any correction happening here, even in a traction film, very mildly correcting. And this we did a multiple polysegmental posterior column osteotomies, and then we got a good alignment here. This is again, you can see the lateral film, preoperative, postoperative, a good correction. Then in severe congenital kyphoscoliosis like this, where there is a very severe multiple vertebral bodies are involved. This needs resection of the apex. Vertebral column resection has been done here. And this is one of the problems what we generally face is because of the excessive shortening of the column, there is a certain amount of indenting of the dura. So when such a thing happens, it is very important that you can distract the column a bit so that you place additional bone in the front and sort of shallow the sulcus out. And this is the pre and post operative picture. And of course, severe rigid scoliosis like this, sometimes we can still do a vertebral column dissection at one level and get a reasonable correction. And again, we can see that we get more sagittal correction than coronal correction. This is again a very severe kyphoscoliotic deformity. Almost it is a severe end-stage kyphosis, some sort of a bone-on-bone deformity, some sort of a hissing spine deformity. You can see she also had a congenital cardiac anomaly for which surgery was done, and then this was the post-operative correction for her using vertebral column dissection. So, in summary, posterior column osteotomies ranging from posterior column osteotomies to vertebral column dissection are excellent tools in the hands of spine surgeon to be used judiciously so as to give a good and effective correction to the patients with spinal deformities. Thank you.
Thanks, Sudhi. That gives us an opportunity to discuss various aspects of VCR and how dangerous they can be. I'll start with Dr. Arvind Jaiswal. I think you're one of the largest experience in this. So, in all those patients of VCR where you've lost signals, where retrospectively thinking, in which part of the game is it most dangerous?
Surya Prakash, please stop sharing.
Yeah, I have stopped sharing. 1 minute.
Yeah. The Surya Prakash hasn't stopped. Surya Prakash, please stop sharing.
Yes, I've done that.
Yeah, Dr. Jaiswal, are you there? Ajay, can you take up that question? So Dr. Jaiswal is back. Yeah, Dr. Jaiswal, yes. I wanted to ask you that in all your patients of VCR in which you've lost signals, retrospectively thinking, which part of the job is the most dangerous and which part of it really needs to be very careful about?
I think as I asked you in the beginning, the most, especially if there is a scoliosis element to it, and you rightly pointed out, is the medial side, the concave side, pedicle which hugs and digs into it. And most of the time, that's very correct, and the signals drop. Right, that is the in a severe scoliosis is the concave side of the pedicle at the apex. So that is the area which we tend to go in first. And if I can digress a bit on this, if you allow me, we worked it out in a different way in a severe scoliosis. What we now started doing it, and which I discussed with Dr. Shuffleberger also, he does the same thing. Instead of cutting the medial pedicle or the concave pedicle off, we'll cut the convex pedicle, the classical asymmetrical one, and do the osteotomy, the VCR, and go above the concave apical pedicle, go into the disc space. So you'll have your completion. It's almost like the type 4 of Schwab's, where you enter into the disc space, and that helps you not to release your concave pedicle, not to get rid of your concave pedicle. And that in severe scoliosis, I found it very useful. You don't even touch the medial pedicle, the concave pedicle. You go into the disc space in that area. Are you with me there? Are you there with me? Yeah,
yes.
You understand what I'm saying? So convex side, get the pedicle out, get the good wedge, and then enter into the on the concave side into the disc space. Clear the disc space out, which you can do it very efficiently. And then when you instrument and give your cantilever off, that is. So that's over the period of time I worked out.
Thanks. The other aspect of VCR, which is very, very dangerous, other than the neurological deficit, is the blood loss. And both of them go hand in hand together. If you have severe blood loss, you'll end up into hypertension where you lose signals in the cord. So can I ask Dr. Sajan Hegde regarding his tips of preventing blood loss, severe catastrophic blood loss in VCR surgery?
I think it is meticulous technique. It is making sure that you skeletonize before you start your osteotomies and go in a very measured way. You have to use all these things like flow seal, your your peanuts and everything to pack the bone. If one side is bleeding, then go to the other side, pack it and leave it for some time, come back to it later. So you have to do it in a meticulous manner. If you try to be a little shabby, then the bleeding is horrendous from the venous, the venous blood vessels around near the cord. So that is terrible.
So, I think meticulous technique, and I still remember that is the word he used when I don't know whether you remember or not, when Dr. Lenki came in and was operating on a very horrendous VCR, and myself and you were there also scrubbed up. And when Dr. Lenki was taking a huge lot of time in drilling out the concave pedicle slowly and steadily and taking out the roots, he actually tied a couple of roots and let the cord hang. And then you passed across to me and you said that this guy is highly meticulous, Basu, I tell you. So I still remember those words. Thanks for sharing that, Dr. Sajjan.
Oh, absolutely.
Yeah.
And I just wanted to make a comment when Arvind spoke about leaving the concave pedicle till the last minute. Actually, like Lenke does, you remove a large part of the convex vertebra, do the VCR, partial VCR, then put your correcting temporary rod, correct a little bit. That will open up the concave side a little bit and allow you to access that which is already now loose because of the work that you have done from the convex side. And it becomes easier to remove. And you're less, you're meddling less in that very sensitive area.
So I'll come to Ajay in 1 minute. But before that, as Dr. Jaiswal said, that yes, you take out the concave pedicle, the convex pedicles and the adjoining part of the body and the disc above and all that. And then it becomes loose. And what I've seen Dr. Lenki doing always is after this step, he takes out the roots, a couple of roots on the convexities over which the cord actually gets tethered. And once that is gone and the convex side is completely loose, the cord tends to hang a little bit and
fall away.
And thereby you tend to sort of loosen out the theca on the concavity, the thecal sac on the concavity, and then you can start drilling out. And most of these congenitals, the concave pedicle is as hard as rock. So rather than hitting the osteotomy, it's much more safer, I believe, to drill it out slowly and steadily, put in bone wax and again drill and put in bone wax and again drill. Ajay, you had a comment before I show you.
There are two things when you have to look at when the patient has got a severe deformity. If he doesn't have a neurological deficit, then you can maintain a map at around 70. Good anesthetic technique nowadays, the use of Dexmed, all those things will reduce the map significantly. And when you're doing the corrective maneuvers, the map can come up to 90 or 100. But in the patient with a neurological deficit, it's always preferable to maintain a map of about 90. Otherwise, the hypo situation can induce a neurological deficit much earlier.
I remember
ultrasonic device.
I remember when Lenke was with us, he was insisting on
90 map.
A higher blood pressure.
90 map.
And what I used to do in the 90s, I stopped doing subsequently. So we don't really go for hypotensive anesthesia anymore.
Right, Dr. Jaiswal.
So Saumyajit, the other point which I picked up with Lenki before he came to your place, and we were discussing it, question of sort of reducing your bleeding, and now I do it meticulously, is that you, especially on the convex side, when you cut, or on if your kyphosis on both the sides, when you cut the ribs off and you get onto the lateral part of the vertebral body, right? Make an effort to look at the segmental where it enters. Because once you get into the bone, that starts bleeding massively, and then they'll put your finger, you'll shout at your assistants and things like that. So spend 5 minutes, look for the segmental, and then coagulate it, and then you'll be slightly better off. And then, as Sergeant said, use the other anticoagulants. Yeah.
Right. I'll ask Dheeraj for a final comment before I show you the case.
Yeah. So you asked Jaiswal sir regarding the steps where you are more cautious with changing signals. So adding to that, I am also cautious while correcting the deformity, especially when lamina is touching the cord, especially when we are gradually shortening. Also, one more thing, while correcting the deformity in congenital acute angles, and over a cage, there may be some relative lengthening on the concave side, and which might change the signals on ipsilateral side. Okay, so I'm cautious about relative lengthening as well as what I have mentioned, lamina hitting the cord while correcting the kyphosis.
So we were speaking about this patient, and as you can see, she had a very horrendous deformity, and we started her with halo traction for 2.5 months, built up her physique, built up the, I mean, the deformity. The deformity actually does not correct at the apex, it corrects periapically at the secondary curves. And this is how she, her neurology also improves. All the patients who had a sick cord and I applied halo gravity traction, you can see them walking much better than she was before. And this was the bone model, which with 3D printing nowadays is a routine in our unit. And this helps us to do the VCR, put in the screws, because the screws up and down the vertebrae are so anomalous, they are anatomically so much rotated, it's extremely difficult to visualize them. And this is the VCR which we did. So this is, you can see the cage over which the proximal 3 screws and distal 3 screws were placed. And this is the cage over which we did the correction. And I think we did a reasonably good correction, and she was quite happy with the result. And I intentionally did not go up to the proximal thoracic spine because she's a child. She's 6 years old at this point in time. As you can see, this is the cage locked solidly in place. And this was her. When she went back home, she went back after 3 weeks and showed us all that she could walk much better without support. And we were all quite happy, but this was very short-lived because she came back after 8 months with a persistent spastic paraparesis. Her parents called up and said that she's again not walking, and this time it is, you can see that there is a huge PJK which has happened, and within 8 months, she again lost her cord improvement and became myelopathic and hardly could walk. So this was what we left her with at surgery, and within 8 months, she again has fallen forwards in the upper part, and we again put him on traction again, and this is her again with the traction next time, second time. You can see that her legs are really giving away, and she was now hardly grade 2/5. And this was her post-operative CT. As you can see, these screws, they are actually not pulling up, but they are, you can see that there is an angulation which is developing there. And this is the bone model done again. And this time we use intraoperative traction. We extended the fusion, and this is the fusion going up to T2. This was going up to T2. We used a domino there also. And this is her pre-op, pre-second operative, and that is the post-second operative picture. And this is the second post-operative CT, and this is our second pre-operative CT. And that is her. This time we did not have any sort of inhibitions in putting her on a halo vest. So she's about 3 months, 4 months down the line. She's still on a halo vest, and that's the picture of her walking without with a walker by herself. And she has improved her legs. Definitely she has improved, and it's only about 3 months down the line. I wish to be there. We have the halo vest for at least a year to make sure with the CT scan that everything is consolidated there. And I'm sure she will have a anteroposterior diameter of the thorax as well as a vertical diameter of the thorax, which is compromised. And that's the best we could do for her. Any comments before we?
Yeah, Saumyajit,
Yeah.
I can quite understand why you had issues with your upper construct with the severe kyphosis, and you did a great job. But, in these cases, I feel the pedicle screws can give you only so much of a hold, and you need to replenish that either with a claw type construct of hooks or with bands, sublaminar bands to support and to prevent your hook screws from backing out, at least at the top of the construct. And that at least prevents the screws from backing out, because in these children, the hold that you get is very, 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 very tenuous. And you need to, of course, support them with the halo vest and other things till they till they heal. Great job, but this is what I would do, use these constructs at the top.
Yeah, thanks for your suggestions. So the only problem was that pediatric hooks were not available for this 6-year-old child. This child was 6 years when we operated on him, and she was only 20 kilos. You could understand by the video also, she was a very, very thin and slim girl. And as it is, putting in pedicle screws, the pediatric version of the pedicle screws, 4mm screws, 4-5 rods, whichever is available in the Indian context, was putting the skin closer at risk. And hooks were just not available with us. So if we would have loved to put on the proximal hooks. Sir, Dr. Jaiswal.
Yeah, it's a big problem. You have to understand that it's a growing spine, and we have to respect that, right? And yes, she had neurological deficit, and your answer was correct that you put them in a halo. We don't even put on a sliding. We just put them on a halo vest, the vest resting onto the iliac crest. And the neurology improved because it's a single level vertebral defect with the kyphosis, right? So that would improve. Now the question is how to correct and maintain the deformity. Now we worked out a solution on that, that particularly if there's a neurological compromise there, it's a mid-thoracic region, you do a small osteotomy, right? And fix just one above, one below, right? That will not hold your entire spine. But for holding a VCR properly, you'll have to fix entire thoracic spine in a 6-year, 5-year-old child. That is going to have a big problem because you need, like your failure was because you stopped at T4 or something. You need to go right up to the top with a hook or whatever. But then what you're jeopardizing is your growth of the spine and growth of the chest wall. So one solution is that, and we found that effective, is do a local osteotomy, correct it, neurologically decompress it, and then use a growing device above and below, a Sheila type or a growth rod. That will hold the osteotomy together, get it decompressed, and yet it will allow your chest and your spine to grow. And it would not prevent your PJK to that extent. Right? So once you do an osteotomy and viscera, whatever, you need to fix long to hold it, and otherwise they will topple up like this. But in a small child, a 6-year-old child, if you go right to T2 or T1, then you lose your growth potential and the chest.
Yeah. The only issue here was there were 3 vertebrae which were completely congenitally affected. There were 3 vertebrae which were all clamped into one, and they were all, the apex was digging into the cord. So osteotomy would definitely mean taking out at least one of those apical hemivertebrae completely out. And as you do not have any hold, then if you have to really make it short, then you'll have to have one-sided rod. You take out one hemi, and you can only put in one screw up and one screw down in those 2 vertebrae.
Okay,
the other pedicles are not there.
But
was the issue.
You're using a distraction to get rid of that, right? So on top, you have your anchors on top, you have your anchors on bottom. Even if you go down to L1, L2, you will still have the anchors to get your biomechanical lever on there.
So it is like offloading your construct.
Exactly, and allowing it to grow. Exactly.
Yes.
I have a suggestion here because
you have to correct it. One level decompression and osteotomy, and let the spine grow.
I have a suggestion here. By doing halopelvic, I think a fantastic job has been done. By halotraction, you've got a very good correction of deformity reasonably. And then, as Dr. Jaiswal has suggested, do a very modest decompression and an in situ sort of a fixation at the apex. And then probably I would take do an anterior surgery and put a proper fibular strut in the front. That way, I have seen most of the cases where anterior surgeries have been done, anterior fusions have been done. These junctional issues are very less. I don't know. I won't comment from other people.
These cases are, defeaters from the very start. At the one end of it, you have to have a neurological deficit, and the other end, you have to save the height of the thoracic spine to prevent thoracic insufficiency. On the other hand, you'll have to control deformity. All these 3 actually sort of bogs down the surgeon to a point where he really gets confused. Without wasting time, sir, I'll ask you to share your screen. I'll come back with the case later on so that you can tell us when do you do anterior release and when do you would really like us to understand that thoracotomy is really, really safe and you can do it. Every one of us can do it. as well as you do?
It's not a question of as well as I can do. It's just that you know what you do. And last case, you got to think out of your hat, and there's no protocol that has really been worked out as yet. So you got to take it and observe these kids as you go along. And I think you did the right thing to start with and follow your helipage. So my brief given by Saumyajit is talk about anterior release and posterior correction, and I strongly believe in that. It's not that I just do it with a thing, and I strongly believe in this. Is that in the severe, long-standing, rigid scoliosis, there are contractions of the.
Please share your screen, sir.
It's not shared?
No.
Oh, I'm sorry. How do I get out then? Okay, let me see. Result. No. Okay. I don't know where I am.
Yes, now it's shared. Yes.
Now it's shared? Okay, right.
Yes.
Sorry about that. Yeah. Okay. So like I said, the long-standing, they develop contractures of subtoting ligaments, intervertebral joint, costovertebral joints, and most of these defects in soft tissue and in the bony defects are situated anteriorly, and we all know that, isn't it? So why should we shy away where the defect is? If the defect is there in the thoracic spine, we don't do it in L1. We do a VCR and osteotomy at the site. So the defect is there. So why not go anteriorly and address your contractures and anterior defects or the bony defect anteriorly, in fact, thing. And that's what the rationale for anterior release is. And when we talk of anterior release, we're talking of an apical 3-4 space release and excision of rib heads and complete excision of the disc space, including the ALL, so that once you completely remove the disc all around, PLL is exposed, and if they're very, very rigid, we go and even release the PLL. So that would give you a lot of flexibility, and it sort of loosens up your rigidity curve, and everything is moved interiorly. Like in any basic orthopedic deformity, you loosen your soft tissues there, and it becomes very flexible. The deformity as such. So and there's ample biomechanical evidence now that if once you do anterior releases, it increases flexibility. It gives it increases your coupled motion over the individual vertebra which are tethered together, and it enhances rotational deformity correction and your overall correction of the deformity. There are cadaveric evidence to show that anterior release does a great job. And in this particular cadaveric study, it says that dissection of anterior structure led to 140% to 288% increase in rotation and flexibility. Whereas if you look at just posterior releases in the same cadaveric study, the increase in mobility was 8.8% to 71.9%. So why hesitate in going anteriorly? It takes about an hour or two and less of blood loss, and do a good anterior release to supplement it. Now coming on to the clinical evidence, the anterior release itself, people have quantified it. It gives 21% correction by just anterior release alone in these severe rigid deformities more than 80-90 degrees. And that has been our experience, and I'm sharing you our published data. And where in a severe correction of more than 100, in a severe deformity more than 100 degree, just by doing anterior release alone, without doing any osteotomies anteriorly, you get nearly 30% correction. Overall, of course, you get about 77% correction. But let's concentrate on just the anterior release, 30%. And we published that. So because we do it in a staged manner and with a gap of about a week or so after stage 1, if you radiologically, we are able to quantify that. So an 82 degree curve, after just pure simple anterior release corrected to 58%, about 30% correction. And that's what is shown here. Yes, anterior release can also be done endoscopically, and there are a lot of literature on that, but it somehow did not get very popular, because especially in severe scoliosis because there's hardly any scope and any place left to introduce your thoracoscope to do a good thorough decompression there. A webinar here with Sukin Shah as the chairperson, and people like Zan Sukato and others in the webinar, and even the Americans here, Sergeant, even the Americans here have said that for 90-degree curve plus, adding an anterior release is a good idea, and a lot of them are resorting down to that. But for 70 to 90 degrees, there's no need for an anterior release. So to share you our experience with a few slides. As I said, we do it as a stage surgery. In anterior surgery, we do a radical release. That means all around, remove the rib head on the convex side, completely remove the discectomy. 7 days to 10 days later, we do a second stage in which we do a posterior releases. And if you look at the osteotomy, these are simple osteotomies, which Surya Prakash has labeled them as posterior column osteotomies, the Ponti's osteotomy, the SPO's osteotomy. It's not the radical osteotomies which you need to do PSOs and others. So just by adding 4 or 5 SPOs or Ponti's osteotomy and by instrumentation, you get a decent correction, as we have published. 21 patients, 13 idiopathic, 6 congenital, 2 syndromic, 116 degrees mean curve corrected by anterior release by 29%, and then final correction about 70%. And we strongly believe that the anterior release at the apex, the rigid apex, provides nearly 30% correction, so that the extent of osteotomies in the second stage posteriorly is substantially reduced, allowing for a good correction. So you don't need to do a PSO. Just simple Ponti's osteotomy can get through to it. And here, for example, a 116-degree curve, a very rigid curve, after anterior release, only corrected to 70 degrees, and then you go back, do your Ponti's osteotomy at 3-4 levels, and bring in your instrumentation. I use a very dense instrumentation, especially for these rigid curves all along the concave side and skip on the convex side, and I use hooks at the top. So that's a preference that I have, and you're able to correct radiologically good coronal correction, and clinically even the cross rib correction is there by good anterior release, no thoracoplasty at all in this particular child. And if you can go back in the chest X-ray, you can see the ribs are all intact. There are no ribs which have been, except this rib where you went anteriorly. So, and this has been reported by Jürgen Harm's team also, a 2-stage procedure. And they say when you do a good anterior release, you shorten the spine. When you shorten the spine, then you can derotate the spine in a better manner. The whole column can be derotated. It also helps you in correcting the kyphoscoliosis, the hypokyphosis, which is classically there in thoracic spine in a classical AIS. And of course, then you get a good 3-dimensional correction without doing a costoplasty or thoracoplasty. What is also important, they've said the shortening also gets to circumvent your hypokyphosis correction. That's a big point there. But over the last decade or a decade and a half, anterior surgeries have fallen out of favor. And one of the main reasons touted for that is that, right, that pulmonary function is deranged in anterior surgery. It's sort of a myth, and Sergeant and we always talk about that, and we realize that's not in a good, if there's a good setup, that's not really a big issue there. And these newer articles, and this particularly systemic review on meta-analysis on pulmonary function different approaches, proves that 22 studies have been included in this with a meticulously analyzed and systemically reviewed of these articles that suggest, it's very interesting, anterior approach, anterior fusion does not lead to significant change in pulmonary function 2 years after surgery. There you are. So that myth is really is just a fear that you got. Now, if you yes, you can avoid a second stage 1 surgery anterior release. You can do it as all of you have said. You do osteotomy, do a VCR or a 3-column osteotomy and get a good correction. But as you all understand, these are high-end osteotomy, morbid procedures with great blood loss. Sorry, Sergeant, the slide which you projected was from our article, and Bradford did not do a release anterior and posterior osteotomy. They did, Bradford group in early days would do an anterior osteotomy and the posterior osteotomy, a combined VCR, and that led to about 5 liters of blood loss. Now, not in the classical VCRs or anterior or posterior. I didn't mention, but with our total blood loss is about 1.5 liters anterior posterior combined. And of course, a long operative period when you have your VCR. What is also very important is potentially you have neurological deficit. And Sales Sook's article says that with his VCRs, he's had 14% of neurological deficit, 6 of them permanent, and total complication of 40%. So potentially, we all recognize there is a high complication rate potentially. The SRS morbidity and mortality database, 19,000 cases. If you analyze these complications in this huge database, you see that without osteotomy, a new neurological complication is 0.9. Once you do an osteotomy, whichever form, the neurological neurological problems jump up twofold. This data also looked at the different types of osteotomy. Very interestingly, SPOs have minimal of complications, but when you get into the PSOs and the vertebral column resections, this jumps to 7 times. So try and avoid these morbid big osteotomies. If you can get away with smaller osteotomies, why not do it? And your anterior releases would help you to get rid of your major osteotomies. Another very interesting point, when we lined up all these, when we were doing this paper, when we lined up all these different articles of different procedures, the anterior release, posterior instrumentation, anterior with halopelvic instrumentation, and the VCRs. What is interesting is the amount of correction that you get is between 55 to 67 degrees. So they're more or less the same. So why subject this patient to these potentially dangerous procedures where you can do the same correction with simpler surgeries? And in fact, we got a better correction of 70 plus correction in our series. So in summary, an anterior release is sound biomechanically to increase mobility of the rigid curve. It favors this derotation, and so that you can avoid your costoplastys later on. Correction of hypokyphosis is their major advantage. Shortens your thoracic spine vertebrae in there. And of course, pulmonary function, as I showed you, is an exaggerated fear. If you have a good setup, Sergeant also agrees with that. Anterior surgeries can be added on, and anterior release is a good adjunct in these severe cases. Yes, add on a preoperative halo, it really definitely helps. But then by adding anterior release, you need not go and do big osteotomies. Multiple simpler osteotomy, posterior column, Pontes would suffice. Thank you very much.
Thank you, sir. While you de-share the screen, can I ask Dheeraj, in your setup, are you doing anterior releases, and if so, which patients are you picking up for anterior releases?
So in my setup, I am not a surgeon who favors anterior surgery. I like to go single stage all posterior, do multiple level PCOs. I might do in a curve more than 120 degree curve, which is showing more less than 20 degree of correction. I like to put him on halotraction. Otherwise, I am not a surgeon going for anterior surgery. And I'm quite happy with all posterior, and I'm getting similar correction to what Arvind Jaiswal. I think the correction in my cases is because of high screw density. We don't hesitate to take bicortical pulses, and we never use a screw size less than 5.5. Less than 5.
Right. And going back to Dr. Jaiswal, do you take this opportunity when you're doing anterior surgeries to do internal rib excisions, which Dr. Bhojaraj still advocates for rib hump excision?
Yeah, it automatically happens, Saumyajit, because like I said, all the apical releases that you would do. It'll end up doing about 4 to 5. You remove the rib head. Once you remove the rib head and a small portion of the adjoining rib, then you automatically give flexibility to the thoracic spine. So when you go back posteriorly, you'll be surprised after you're able to derotate it. It will correct on its own. So you don't have to remove lot of rib excision. I've stopped doing that. Only on the medial. Even if I'm doing an all posterior correction, I would just remove the medial end of the rib head and the middle of the rib head, so as to leave all the strap muscles intact over the rib, so that post-operatively the breathing is less painful and is better.
Right. So this is just another example of what you did. This is Anchal, who is a 13-year-old female, and the peculiarity is that from 57 to 80 to 130 all happened in 2 years' time. And this is what was very peculiar. And in spite of our valiant efforts, we could not find anything but anything else but an idiopathic scoliosis. So she was a 130-degree idiopathic scoliosis. So, and from with traction, she corrected on to 109. With bolster, she corrected to 101. With bending, she corrected to 112. And at the end of the day, it was 130 on her standing films. As you can see, it was a huge curve, which was the CT scan. And I was very hopeful that we could find some heavy or some unsegmented bar. Unfortunately, we could not. Surgical planning was anterior release, followed by halogravity traction, followed by posterior column, so posterior correction of deformity. And as this was an angular deformity, not sharp one, it was a smooth one. So we planned that we would have multiple PCOs, or posterior column osteotomies, or the Pontes osteotomies. So a transthoracic approach, as Dr. Jaiswal showed us, and followed by halogravity traction for about 3 weeks, and that corrected to 97. And in our hands also, we did find that from 132 to 197, that means about 30 or 35% of the correction was straight away done with anterior release and halogravity traction. This was after putting in the screws, and that was the final correction, 57, and that was her pre and post-op, 130 to 97 to 57. And we still could not get a good sagittal profile, but this is immediate post-op, and that is 3 months down the line. And as you can see, this is actually not the true representation of the sagittal profile, because the hump which is coming in is actually the right rib hump, and this is her reasonably well balanced. I wouldn't say that the sagittal profile is extremely well built, but that was just about all. Before I'll stop sharing here and reserve my final case, in which I would show the justification of a halo after Ajoy takes up his talk. So Ajoy's talk is the last one. We have about 15 minutes to go. Ajoy's lecture will be followed up by a small case discussion, and then we'll wrap up.
Thank you, Basu. Good evening, everybody. What is the role of halogravity traction in severe spinal deformities? The question is, when do you use it? Why do you use it? How do you use it? What does it do? And what is the final outcome? When you look at patients with severe spinal deformities, it's not only the surgical challenge, but the goals of surgery in these particular patients is entirely different. Some of them could be undernourished. They could have respiratory pulmonary function disease, poor cardiac status, and also the fact that the surgical consideration involves significant change because of the orientation of the pedicles, the loss of anatomical landmarks for us to put screws, increased blood loss, and the higher chances of neurological deficit. Therefore, the goals in these patients should be to get a reasonably good balance, to have a neurological safety, and also the need to bring down the need for an aggressive osteotomies. The optimal surgery will be one which gives us an acceptable deformity correction, and the ideal surgery would be a single-stage surgery, preferably a posterior surgery if possible, but it could be one which avoids the need for a 3-column surgery as much as possible. Why do you use halogravity traction? Because traction could be an answer. It is basically, what does the traction does? It causes a gradual stretching of the ligamentous structures of the spine, the rib cage, and the surrounding soft tissues. As a result, during the final surgery, it decreases the need for VCR. It increases the amount of correction, and also the corrective force is decreased, hence decreasing the chance of implant failure. The spinal cord gets adopted by traction over a period of 4 to 6 weeks and decreases the risk of neurological deterioration during the surgical correction process. It's not something new. Even in Mahabharat, there is a history of traction application with Lord Krishna applied axial traction to correct a hunchback of a Kubja, a devotee. The concept of halo first came in 1959 by Vernon, further popularized by Dewald in 1967. And this is how the evolution of traction apparatus in scoliosis did happen, from halo device to halo pelvic traction to halo femoral traction to halo gravity traction. What I am going to talk is basically about the halo gravity traction. The advantages is that it's an ambulatory traction when compared to other form of traction. Patient is relatively much more comfortable. It provides a gradual correction of the curve. It also improves the trunk decompensation. And since the correction which happens in the preoperative stage, the neurological status could be easily monitored. What are the types of halogravity traction? We have the homogeneous, we have the heterogeneous. Homogeneous is a situation when the primary mode of treatment initiated will be a halogravity traction. Heterogeneous is the one which Dr. Basu spoke to about, where there has been an intervention like a previous surgery, like an anterior release or a posterior release, and this is followed by a halogravity traction. What is the protocol? Usually it's preferable to use 4 or up to 6 pins under a local anesthesia. On day 1, there is no traction, but within the first week, we try to put about 20% of the body weight and then increase it by about 10% of the body weight every 5 days to 7 days. And usually it goes to about 30 to 50%. 50% is the usual target what we keep. And usually we should be able to achieve that in a period of around 4 weeks' time. It's important that the traction duration should be at least 20 hours per day. What is the advantage? You can see they were able to read, they were able to use computers. They are also able to walk. But the plateau phase usually reaches at about 4 weeks, at least in our experience. And this is the advantage of the halogravity traction, because it's an ambulatory traction. If they do not have a neurological deficit, they will be able to walk. If they've got a significant neurological compromise, at least a wheelchair immobilization. And this, as you can see, the patient's height increases. You see the amount of correction that can be achieved over a period of 3 to 4 weeks. Significant degree of correction happens in the first 2 to 3 weeks, and then slowly it plateaus out. But as you can see, in a patient with a scoliosis per se, we do not do a VCR in most of this patient and try to get the balance as much as possible. And what is the effect of the halogravity traction? If you look at the literature, majority of the literature gives it about 20 to 30% of correction of the severe deformity in the halogravity traction. But if you look at the 2 recent papers which has come out of China, which is published, one in Spine and other in a BMC journal, they have reported that it gives a correction of about 50%. I'm not exactly certain, because if you look at the case examples, what they have put, it really doesn't look like a very severe scoliosis. Therefore, it's probably some degree of flexible scoliosis, and that's why the percentage of correction is much higher. Maybe you can achieve that in a case similar like this with patients which we had 2 sisters, Marfanite, with a significant degree of curves. And you can see one of the sisters, the case with the traction improved from 134 to 83, and this is the final correction. The other sister, the traction from 98 degrees became 47 degrees, and that's the final correction. And this is the preoperative with traction, and this is the postoperative clinical feature. It is possible to get 50% in curves which are basically S-shaped, and which the curves is about 100 degrees, and in a neuromuscular element, maybe it is S. But most of the rigid deformity, you may not be able to achieve that. In our experience of 26 patients, now it's about 35 patients, you can look at the fact that curve is not only a primary curve, but also the curves above and below, the compensatory curves also have become rigid, and it causes a coronal imbalance. It causes an apical vertical translation. And if you can see in this slide as such, you know it's not only corrects the main curve, the significant amount of correction also which contributes to the correction happens in the compensatory curves above and below. There is a difference. In idiopathic scoliosis, the majority of the curve correction happens in the primary curve, whereas in a congenital scoliosis, when you put on a halo, the majority of the correction doesn't happen in the primary curve, It happens in the compensatory curves above and the compensatory curves below. And as I mentioned earlier, it plateaus out, at least in our experience, for about 4 to 5 weeks. And that's one of the reasons why we keep usually for 4 to 6 weeks. But however, in children who are significantly a poor nutrition, who respiratory compromise it more, we may have to keep it for another 4 to 5 weeks more to improve the general condition and also the respiratory function. Halogravity traction has got a pan-vertebral spinal effect. As I mentioned, it improves also the secondary curves, and the final correction is aiming to balance between the head and over to the pelvis. This is the problem of the secondary curve, and all these problems can be addressed. As you can see, the apical vertebral translation, the cortopelvic impingement, the shoulder height difference, all are significantly improved by putting on a preoperative halo. It also improves the pulmonary function. Significantly, the PVC and the PV1 also statistically significantly improves. There is an improvement in the height gain for about 4 centimeters. Weight gain, it will be about 3 to 5 kg of weight gain improvement. Therefore, the other most major important aspect of a halogravity traction, it's an ambulant one. Better chest physiotherapy provides the problem associated with decubitus. And during surgery, it reduces the neurological complications. What we have found very significantly in this halogravity patients is the need for an ICU stay or a post-operative ventilation or a chest-related complications. Therefore, you look at the case, therefore, you have to differentiate when you have a patient whom you have put on a halo, whether their component is mainly scoliosis or a component is mainly kyphosis. If you look at scoliosis, our aim is to balance the spine, the head over the pelvis, rather than looking at the correction between the upper end fixation and the lower end fixation. Whereas in a kyphosis, usually you'll end up needing a vertebrectomy. And this is what the improvement of 128 degrees to 101 degrees over a period of time. And if you see, this is the final correction after you do a VCR. And this is a case of purely mainly scoliosis component rather than being a kyphosis component. If you look at the radiological picture, it may not look dramatically that much significantly straight, but what we are aiming is to balance the spine. We do not prefer to do a VCR in a patient who has got a predominantly scoliosis component. Whereas in a patient with kyphosis, we would always prefer to do a vertebrectomy in this scenario, because our aim is to prevent the cord impingement that is happening because of the kyphosis element. And this is the effect of halogravity traction in the final correction. As Basu mentioned, one of the other important things what we have observed also in our series is patients with neurological impairment. They tend to improve their neurology when they are on a halogravity traction. And it makes your surgery much more simpler and more easier to do when you are doing this particular procedure. This is a patient who had a neurofibromatosis, and a surgeon had it gone in anteriorly, a brave surgeon, but unfortunately the implant failed. We put them on a halogravity traction, excised the superior part of the screws, superior part of the rod, and removed the screws which were causing problems, and then extended the fixation proximally to achieve a satisfactory degree of correction. Also to add, we are not only limited to a thoracic or a thoracolumbar deformity. We also used in patients with a fixed kyphosis deformity, as in this patient with neurofibromatosis. And as you can see, the gradual improvement of correction from 126 degrees to 84 degrees with the halogravity traction. And this is the final correction. Complications do happen, but our major complication has been the pin loosening and rarely pin infection. We haven't had problems like brain abscess. Neurological deficit has been reported in the early literature series. We haven't had cranial nerve palsies. You need to monitor them. You need to look for the distraction in the cervical X-rays to see whether the cervical facet joints are distracting. Look for the cranial nerves, and usually pin loosening and pin infections are some of the major complications. Is there any contraindication? In my book, only when you think the skull thickness, the skull wall thickness is significantly lesser, they may not be ideal candidates, and these children are probably not ideal candidates even for a surgical component. Overall, it's a very good concept, and especially when you don't know what to do in a child who has got a significant deformity, just put on halo. Itself, the deformity starts to gradually correct itself, and then it gives the idea of what the best you can do for that particular patient. Therefore, it's an ideal case for a severe scoliotic deformity, rigid kyphoscoliotic deformity, And even in for kyphosis, it's an ambulant, usually for 4 to 6 weeks, ideal for 20 hours of a day. Thank you very much.
Thanks, Ajay. That was an excellent talk. Before we go into any further, has anybody seen a brain abscess with a halo gravity traction? Dr. Jaiswal, Dr. Sajan Hegde.
Not a brain abscess.
Yeah, so
but a subcutaneous abscess, yes, not a deep abscess. And in the days in 80s and we used to use a lot of halopelvic traction. So that we've seen cranial nerve palsies, which was corrected by undoing the halo. But that's about all. And of course, the loosening of the pin is superficial infection, but not a deep infection. No.
So this is a female. This is the last case of discussion. We'll wrap up with this case. It's a relatively small case. So it's a 12-year-old female, and I don't think I have seen a deformity like this ever in my life. With the patient initially having noticed the deformity at 2 years, known patient was neurofibromatosis, presented to me with shortness of breath and gait disturbance, with back pain and weakness of both lower limbs. And this is her. If you look at this patient, her sternum was completely protruding outwards. It was a dislocation of the sternum subsequent to settling of the thoracic spine into the thoracic cavity, which Dr. Rajshekharan once had a patient, and I know he termed the word as anaconda spine. And this is something which I had never seen before, due to the fact that the neck and the upper part of the thorax was into such a severe kyphoscoliosis, that it was going into the thoracic inlet. That led to the sternal dislocation. And the manubrium sterni is something which you can see pointing towards you, and this is the manubrium sterni. And this is the manubrium sterni which is going out. That is because of the huge proximal thoracic kyphosis, in which the neck is actually settling down into the thorax, and it is going in as if it is invaginating down the thoracic inlet. Initially, at the age of 3 years, these were the X-rays which the mom had could fish out, and you can see at this point in time she had a proximal thoracic curve, and she did visit the Christian Medical College at Vellore when she was about 3 or 4 years, but something happened, and they never got treatment. And this is the dural ectasia and all the telltale features of the rib getting dislocated and hitting on the cord, which you all have in neurofibromatosis. These are the recent investigations. As you can see, this is C2, and this is something like T4 or T5, and everything is no neck, everything is going invading into the thoracic cavity. And this is her CT scan. And as it is proximal, you can see that this is something which is going deep down. This is a horizontal part of the spine. And she presented to us in 2017. Halo gravity application was done. I did not know whether I could treat this patient or not, but she was panting and she was myelopathic. She would hardly stand and walk a few steps on a wobbly gait. And so I told the mother that I'm just going to put on a halo and wait and watch to see whatever happens. And then in October, December 2017, she had a halo gravity application, and after 3 months, she was put on halo gravity traction for 3 months. And after 3 months, we planned for posterior deformity correction, at least in situ fusion. But the procedure had to be abandoned because of very poor purchase on pedicle. I ultimately went up to C6 and C7. Also, there was no purchase, and the lamina was completely sort of destroyed, eaten up. No hold was possible. And there was a prolonged period of half an hour where we lost all signals. There was a huge blood loss. So I had to bite the bullet and say to my anesthetist that I am going to withdraw. I just did the in situ fusion with posterolateral bone grafts, and I had access to BMP, knowing well that it is an off-label usage for kids. She is 14 years. I did put on BMP and went on with postoperative halo vest immobilization, praying to God that it will heal and it will fuse. We know that NF is notorious for pseudoarthrosis, but still I just prayed to God. And on October 2018, that means nearly a year down the line, about 10 months, she presented with severe headache and repeated vomiting. and it was diagnosed case of right temporal brain abscess. Ultimately, a craniotomy had to be done, and this is the abscess. This is the contrast film. You can show this ring enhancement in the temporal lobe, and that the entire abscess wall had to be taken out. And this was her postoperative CT, good resolution. And this is after 1 year, where ultimately I could take a
I think sir is disconnected.
I think we have lost Dr. Basu.
Yeah. Ajay sir, I just want to ask the case you have shown the revision in a neurofibromatosis where there was already anterior reconstruction done. So what we have done for the anterior part?
Basu, taken over. Thanks. Yeah.
So the case you have shown a neurofibromatosis with a severe deformity, which has already done, anterior surgery was already done. It was a revised case.
No, it was not an anterior surgery already done. Because of want of time, I just pushed it forward. It's a patient of neurofibromatosis with a cervical deformity. We put on a halo, did the anterior surgery, but when we tried to position prone, the patient had a vagal stimulation, bradycardia. Therefore, we had to reposition the patient. And then we found out that it is mainly because the thoracic inlet was compressing on the vagus. We had to excise the lateral end of the clavicle, which allowed us repositioning after a few days and then do the posterior part of the surgery. It's called a basalt-Zarek reflex, wherein the vagus gets compressed in the thoracic inlet, causing bradycardia. Whenever you position prone, there is a compression and it causes bradycardia.
Welcome,
yeah.
Basu.
Sorry, I went again. There was a very bad internet connection error. So have you, anybody of you have seen this brain abscess? I don't think I've, this is very horrendous. But the good thing is that the patient came out absolutely safe, and now it's 2 years down the line. As you can see, it is October 2017 that we put it in, and now it's October 2020. It's 3 years. Still, she's still walking about, and she's very, very happy for so far as her anterior deformity is concerned. Ajay, could you see the last slide in which we?
No, the last slides we couldn't see. The final.
I'll just take out the last slide once.
But clinically, she corrected very, very well. Yeah, that's great.
I'll just show you the last slide again.
A word of caution when you use the halo gravity traction, because most of us use the halo gravity traction of which are manufactured in India. The pins doesn't have a pressure, therefore the chances of it may perforate inside is significantly higher. Therefore, it's always better to get an X-ray done post-operatively and be sure that the fixation is adequate. You're not gone in significantly more, because most of them patients are very poor, and we can't afford to use an imported halo traction in majority of these patients.
So this is the pre and post-operative pictures. Can you see it now?
Yeah, brilliant. Yeah.
And this is her post-operative current status. She's now walking up. She's about grade 4. She's a little bit spastic, but considering that she was grade 2 and could hardly walk, she's not panting anymore. So it's 3 years down the line. This is her repeat CT scan. This is the repeat X-ray. And if you see pre-op versus post-op, there is a significant amount of correction. At least you can see the neck now. You could not see anything there. And considering that it is nearly 3 years post-operative, I think it is fused. So this is the post-op, and this is the pre-op. And you can see that there is a thick layer of bone which is forming. Part of it might be BMP, and part of it might be local bone. So that's it. Before we end, I'll just ask each one of the panelists to one specific question. I'll start off with Dheeraj. So Dheeraj, if you find that the scoliosis is extremely rigid and all sorts of traction film and bolster film is not giving you any correction, you do not find that it is a congenital case. So would you accept that it is completely rigid, or would you try to strive something more like under GA traction or or intraoperative traction to see whether it is flexible or not?
No, sir. If it's absolutely rigid and not bending, so I will just go for a CT and MR to look for any bony anomaly or any fusion bar which might be missed in a AIS looking spine. We may have some bony fusions. I will just look at a CT for that. Otherwise, I won't do any other.
Right. And Dr. Hegre, can you think of one reason why you really walked away from anterior surgeries?
Oh, no, I haven't walked away. I just feel there is less need for it since I use halo traction in severe deformities. I feel less need for it. What I would have achieved with an anterior surgery, I now achieve with the traction. Having said that, I do consider, I don't know why Arvind didn't mention this, but when I do these releases, I also sometimes fix that rigid part of the, correct to the extent possible and fix it anteriorly. I used to do it in the 90s. Just kind of gave up because posterior instrumentation got better. And maybe I'm not seeing those horrendous cases that Saumyajit and John showed. I have a very easy life.
So, Surya Prakash, so given the current scenario that you know that it is medico-legally getting tougher and tougher for all of us, which is the only indication where you'll be hell-bent to do a VCR and not do anything else? A single indication of VCR.
I think a single beautiful indication to do a VCR is a complex anomaly or a kyphoscoliotic anomaly with a posterior corner hemivertebra at thoracolumbar junction. I think that's the one surgery which you can really give patient a good outcome, and at the same time, it's really safe, and actually the deformity helps you to do the surgery better.
So, thank you, Dr. Jaiswal, sir. God gives you two options. One option is a 80-degree rigid kyphotic post-TV deformity without any neurological deficit, without any myelopathy. And another, a congenital hemivertebra with unsegmented bar on the other side, presenting with a scoliosis of 90 degrees, a kyphosis of 88 degrees, and a neurological deficit in the form of early myelopathy. Which are you going to choose?
Second one, because I'm very scared of an acute angular deformity, even an acute kyphotic 70-degree deformity, where I have to do a VCR or any sort of an osteotomy. That is more difficult in my hand rather than a kyphoscoliosis, which I would correct with a
right. So you will ask God to give an S into the K. You will ask God to give S into the K. Okay. A little bit of scoliosis is much better.
I'm not saying
pure absolute kyphosis.
Now I'm
the last question to Ajoy. So when having said that, before asking you this question, I tell you that I'm sold out on halo traction, absolutely sold out. But still, can you think of one case where you would avoid a halo traction in a rigid severe scoliosis?
I'm not exactly certain about that, because when I don't know what to do, if you put on a halo traction, it actually starts unraveling itself, and you know, okay, you have an upper end fixation, you have a lower end fixation. At least there are 2 points which you can definitely depend upon. I don't think so, except for the fact when you think the child is past the stage of being helped and the skull bones are relatively very thinner for you to put a halo. I don't find any indication where you cannot put it. It's a salvage option also.
Right. So before I had this brain abscess, Ajay, I would have had the same answer. But now my answer is somebody who've had a brain abscess, I will never put in a halo.
Okay.
No, even in neurofibromatosis, the bones are very, very thin. You'll be very scared to go inside.
Very, very dicey.
Probably happened in your case. It was a neurofibromatosis or a very severe, osteogenesis imperfecta or a severe osteoporosis. Try and avoid it because it just sinks in. It will just sink in. In neurofibromatosis, particularly, they're very, very soft.
In cranial anomalies, pre-existing cranial anomalies, or pre-existing skull defects, for example, in osteogenesis imperfecta, these patients really, really do not do well with halo. Anyway, I think we are 15 minutes overshot, and every good thing has to come to an end. I learned a lot from all of you, sirs. It was a real pleasure hosting this webinar. I personally thank each and every one of you, and I'm grateful to all the organizers, especially Gautam, Dr. Chabra, and Ajay for asking me to take up the job. And finally, a real word of thanks to all those who are seeing us on OrthoTV. Thanks, Neeraj.
Thank you,
Uh,
sir.
Thanks a
okay,
lot.
thanks to Neeraj and
Thank you.
Neeraj and Sham and OrthoTV for broadcasting this and being a part of this session. Thank you
Thank
all.
you.
Thank you all. Thank you, everybody.